Right, good morning everybody. My name is Michael Watson from the Mental Health Improvement System Support Team. I'm here to talk to you today about Optimising Capacity, part of our Elective Recovery support programme. All the slides and the recording from today, as well as the associated tools and resources, are available on our Futures page. The link is in the slides. Do note this session will be recorded. We've done this in such a way that people can appear in there with their cameras and talk on the microphone in the Q&A session. So please be mindful of that, fact that it's being recorded when you're making your contributions. Next slide, please. So we've been trying to get quite high tech with this. So we've used the Menti system, and we'll be getting your feedback and your input throughout the presentation, and hopefully using some of your feedback to shape the Q&A towards the end. So for those of you that are not familiar with Menti, this is an online voting platform. You can use your smartphone or your computer to log in using the details here. So you can scan the QR code using the camera on your phone, or you can go to the website menti.com on your phone or on your computer and enter the code. As you can see, the code is 55605922. I'll give people sort of 30 seconds to get things fired up. Hopefully you're getting ready for the polls, which we'll be asking you throughout the presentation. So just give people a few more seconds to get logged into the Menti thing, and then we'll jog on. I think actually that the number in the bottom right represents the number of people who've logged into it. So that it seems like people have got the hang of it. And that number is getting closer to the number of people on the webinar. So I think we can probably go to the next slide, please, Louise, but we were flashing up the Menti details again when we have the polls. So welcome, everybody. As I said, my name is Michael Watson. I'm a member of the team. I've worked in the Mental Health Intensive Support Systems team for the last 7 years. And prior to that, I worked in the Elective Care Intensive Support team, delivering support for elective care and cancer in physical health. Prior to that, I worked in acute providers in various operational roles. So I'm here today to talk to you about job planning, activity monitoring and capacity to support elective recovery in mental health, and the support available to you from our team in implementing that. We want this to be as interactive as it realistically can be when it's an online meeting. So various members of the team will talk for around 45 to 50 minutes, interspersed with Menti polls. And then we're going to use some of that Menti information to try to inform the discussion and the Q&A. So there is a Q&A section which you can make appear on the right of your screen. So as we're going through the slides, please do post your questions in the Q&A. If they're routine questions about whether or not you'll get the slides and whether or not it's being recorded, by all means post them, but I can confirm you will get the slides and it is being recorded. And the recording and the slides will be hosted on our Futures site. Throughout the presentation, as I said, you have the opportunity to participate through Menti, and also in the spirit of improvement methodology, as a team, we'll be constantly refining and updating the resources on our Futures site, both as a result of the feedback we get from this session and from our work with systems subsequently. So please do keep in touch with us, engage with us in the team, engage with the chat on the Futures site, and be part of our improvement programme. Next slide, please. So today we're covering optimising capacity. So fundamentally what we're going to be looking at is how to understand clinical capacity by using job plans, how to respond to and identify variance in the theoretical capacity and your actual activity, how to add up your individual capacity through job plans with individual members of staff to create team and service level capacity to use for demand and capacity planning, and using quality improvement approaches to improve productivity where you see variance between activity and capacity. We've got a number of simple checklists which are expressed as questions here, but as checklists on our futures site, and we'll also be introducing our team capacity modelling tool. Next slide, please. So, the Mental Health Improvement System Support Team, we're a small national team and we provide improvement support to systems in population health, quality of care and value for money in mental health care, also learning disability and autism. The team is a mixture of operational managers and people with clinical and managerial experience. Between us, we've got many decades of experience working in the provision of services, and we're majority clinically qualified team as well. We come from a diverse range of backgrounds, like I said, including clinical, data management, governance, operations, and we come together to provide a multidisciplinary approach to providing mental health improvement to systems. Next slide, please. So this Optimising Capacity webinar is the first, if you exclude the introductory session, of our mental health elective recovery programme. So the aim of our programme is to provide mental health providers and systems with the fundamentals of delivering good, timely care. We've tried to address the key building blocks throughout the programme of what good care and good management looks like. As you can see, we'll be dealing over the next coming months with commissioning to optimise delivery, access policies, waiting lists and backlogs, optimising capacity today, pathway mapping, patient tracking and improving flow. We'll be delivering one of these webinars every month or so over the coming months, but all the information is available on our Futures site now. Next slide, please. So, first of all, why is optimising capacity important? So, people who have a mental health condition want and deserve timely access to treatment. Who wouldn't? People who have a mental health condition who are seen more quickly have better outcomes than those with long delays. So people want to be seen quickly, and it's more effective if they're seen quickly. And the staff who are working in mental health provision want the best for their patients, and they want those people with mental health conditions to get the best treatment in the most timely way. So understanding what your capacity is in services and in teams and for individual members of staff gives you clarity on how demand can be met in a timely and effective way. So we all know the pressures on waiting lists in mental health anyway, obviously only been exacerbated by the pandemic. So it's all the more timely that we're looking at how we can maximise capacity in order to deliver treatment as quickly and as effectively as possible. And finally, looking at capacity and comparing that with activity and learning from it can help us to deliver more clinical time and remove some of the administrative and other barriers to delivering clinical care. So optimising capacity is good for patients, good for staff, good for the service. So to put it in a kind of strategic context, and then we'll go into some of the specifics, we've got a kind of cycle of demand and capacity, and we'll be focusing primarily here on the capacity side of things. So looked at a system level, we've got objectives in terms of the pathways which need to be delivered, what the population looks like, how many people need to be seen, what interventions should be received, etc., etc. In order to deliver those strategic objectives, each individual service needs to understand what staffing levels and capacity they have to have in place to meet their bit of the system demand or the system offer. Moving around the circle to then team capacity. So each team within a service is then contributing particular bits to the service offer, whether that's particular interventions, whether that's assessments, whether it's triages or whatever it might be. So the team needs to be able to deliver a certain level of activity in order to meet the demand and meet the need and fit in with the strategic plans. So then down to individual level, each person within the team needs to be contributing their bit towards the overall team capacity. So understanding what each individual is contributing and setting that capacity is crucial to ensuring that they can meet the needs of the people coming through the front door. Once that individual capacity is set, and it's important to monitor delivery at individual level and at team level against plans to ensure that you're actually doing what you're planning to do. And where there are changes in the service or changes in demand, or indeed changes in teams or other organisational structures, you need to be able to identify and respond to those, and also to learn where things are not going so well in order to improve. And then those changes feed back up into your ICB kind of strategic level plans, and round we go. So strategically, we're talking about a kind of constant process of adapting and learning and improving to try to deliver the maximum amount of capacity, maximum amount of activity in order to meet the needs of the population. Next slide, please. So when we're looking at optimising capacity, we're going to be looking at two things, which is capacity and activity. First, we're talking about capacity, or rather, I'm talking about capacity. So this is the number of expected treatment slots to be delivered to patients in the future. So this is the plan. This is not the actual, this is the plan. So it's the number of slots for a particular intervention or an assessment or whatever else it might be that each clinician or practitioner will deliver over a period of time. So X number of slots per week, 3 assessment slots per week, or 7 CBT slots per week, or whatever it might be. So it's what should you be delivering week after week after week, part of your normal work. This should be reviewed regularly to understand if any changes are required, either from the practitioner's point of view or from the service point of view. And then, as I said before, the planned capacity of each individual can be added up to give the expected capacity of a team or of a service. Next slide, please. So I'm now going to pass over to my colleague Sarah, who's going to talk to you a bit more about how we ascertain what that capacity is at individual, team and service level.
Thank you, Michael. Good morning, everybody. My name's Sarah Brennan. I'm one of the mental health improvement advisors within the team. I'm a registered mental health nurse by my clinical background, and prior to joining the team, I've got sort of circa 20 years of experience in provider organisations, holding various roles, clinical, operational and governance roles. So, as Michael said, we're just now going to go into a little bit more detail about what actually is a job plan. I think we'd all agree the most important resource in mental health services is the time of our practitioners. So having systems to plan capacity and monitor delivered capacity are critical to optimising the clinical time available to our patients. If you look at the guidance, you'll see a job plan is described as a prospective professional agreement describing each employee's duties, responsibilities, accountabilities and objectives. It sets out how an employee's working time is spent on specified direct clinical care, specified supporting professional activities and other activities, and NHS responsibilities and external duties. A comprehensive job plan will show the timetabling of scheduled activities and define the number of flexibly timetabled annualised activities. This enables monitoring of an individual employee's annual outputs, particularly when combined with e-rostering. In addition, a job plan should outline an individual's professional objectives for the coming year, including any support the employer will provide to enable the employee to achieve their objectives. So this may include a list of supporting resources or a plan to overcome any relevant barriers to meeting their objectives. So we'll just now, next slide please, we'll go on just to think about what are the benefits of effective job planning. So job planning done well, it provides a shared understanding on how and where clinical resources are best used to deliver outcomes for patients. It provides all clinical staff defined time for learning, reflection and continuous professional development. It enables all clinical staff to find time to engage in the processes for planning and improving service delivery. It helps improve the understanding of the multidisciplinary team's contribution to the patient pathway, and it can improve staff morale, health and well-being. It can also improve staff recruitment and retention through improved job satisfaction, and it can reduce bank and agency usage through effective capacity planning. It can also provide leaders with the information required to plan for developing the skills and resources required in a service. It increases visibility of workforce development needs at all levels really and up to board. And it can provide data to enable the service to understand and respond to changing clinical demand. So now I'm just going to hand over to my colleague Simon, who's going to talk to you a little bit more and think about the sort of that multi-professional element of job planning. Over to you, Simon.
Thank you, Sarah, and hi, good morning, everybody. My name's Simon Bristow. I'm a system improvement advisor in the team, and like Sarah, I'm a mental health nurse by trade, and getting on for 2 decades of working in providers prior to joining the team in NHS England. We are going to go to the interactive bit now. So anybody who didn't scan the QR code on their smartphone at the beginning, please take the opportunity to do so now. This will take you to the page where you can submit answers to the next series of questions. If you don't have access to a smartphone, you can also do this on your computer via the web address on the screen, and then entering the code that is underneath it. So please do that now. We're going to have 30 seconds per slide, so you're going to have to be fairly quick off the mark to get your answers in for each of the questions. So please do jump in. Can I have the next slide, please? So first of all, can we have a straw poll of whether or of who on the call is using job plans to plan and oversee delivery of clinical capacity in your area of work? We're fairly matched at the moment. Our proportion of no's and imparts is increasing. All right, so we've got to a fairly stable point here of reasonable spread between the sort of levels of implementation of job plans, but obviously the central point being more no and more in part than others. Can I have the next slide, please, Louise? So within your organisations, for the people that are using job plans, which staff groups have job plans that are well defined and being consistently used to plan and manage capacity? You can select more than one option for this. Please select all options that apply. So this is lots of medics, secondly psychologists, other therapists, a handful of nurses and support workers, and a singular pharmacist or pharmacy sort of team. Okay, so that is good. That is good. I'm glad to see there's some nurses and support workers in there as well. Is there anybody who's got anybody who has done this with nurses and support workers? I'd be really interested to hear from them about their experiences. So if you could identify yourselves and your areas of work in the Q&A by making a Q&A submission, be really interested to hear about what you have done with that, because it is unusual. Can I have the next slide, please? So I wanted to think a bit about what the different CPD requirements are for different professions. Can you, everyone, this is a pop quiz bit. So can we have people's ideas about how many hours of CPD we think are needed to be completed each year for our medical colleagues? We've got strong preference for 80 hours. Oh no, yeah, it's all go. All right, so somewhere between 60 to 80 to 80 plus is the sort of the biggest body of votes here. So quite a bit. Can I have the next slide, please, Louise? Okay, the same question. How many hours of CPD do we think are required each year for psychology colleagues? Okay, so a mid-range series of submissions for this one. Okay, so we're averaging out, we're sort of, yeah, normally distributed on this one. Can I have the next slide, please, Louise? Same question again. How many hours of CPD do we think are required each year for OTs? You guys are getting really good at this now. We're quick off the mark. All right, looks like lots of people have read the Royal College of OTs guidance. Okay, so we've got strong preference for 20 to 40 hours for OTs. And so we'll move on to our final question of how many hours of CPD do we think are required each year for registered nurses? We've got an optimist, and we are adopting a strong preference for 20 to 40 hours. Got two optimists, more than 80 hours. All right, but we've got a strong preference for 20 to 40 hours on this. Can I have the next slide, please? So the actual requirements are is 50 hours a year for our medical colleagues. The BPS recommends 40 to 80 hours per year for psychologists. The Royal College of OTs has 30 hours of requirement for occupational therapists, and nurses has just shy of 12 hours per year. It's 35 hours over 3 years. And when the Nursing and Midwifery Council did their evaluation of the revalidation requirements that were introduced, whatever they were, some years ago now, 4 years ago, 5 years ago, despite having the lowest annual CPD requirements of all of the professional groups we've looked at, 44% of nurses pre-pandemic described finding it difficult to find the time to undertake that 12 hours a year of CPD, and cited that they felt that they were too busy to be able to find time to do that. Now, anyone that's ever tried to put on any kind of developmental work for nurses in any form, whether it's training, CPD, reflective practice stuff, that will be a familiar picture to people. And this kind of too busy effect is a product of multiple factors, both external structural ones in terms of how we manage different professions' workloads, and internalize things and culture around, this is how we do things, this is who I am as a nurse, and this is how I structure my priorities. And it's a key barrier to engagement in the various different aspects of developmental work that other professions have easier access to around reflective practice, personal development, and engaging in service development initiatives also, QI and whatnot. Can I have the next slide, please? So thinking about nurses as a professional group, there's 700,000 registered with the NMC, so it's the largest collective professional group within the NHS. If you think about how the sort of power dynamics are structured within healthcare and within wider society, until a couple of years ago, the official system for stratifying society in the UK was a 9-point system, and the position of different occupational groups was determined using empirical observations of the power relationship between those occupations and the level of autonomy that they possess. So this is the officially sanctioned, our national way of classifying power and sort of social structure in this country. And nurses were placed in Group 3, the associate, professional and technical occupations, below other higher health professions such as medics and pharmacists. And if anybody wants to do any further reading on the sort of structures of this, Max Weber's the man to look for. Can I have the next slide, please? So, and then pop quiz. So smartphones at the ready, please. Pop quiz, what do you think the demographics are for the nursing workforce gender split? Do we think 90% female, 60% female, 50-50 male, female, 60% male, or 90% male? Okay, so we've got a strong preference for 90% female, some 60% female, and a singular answer for a high proportion of men. Okay, can we have the next slide, please, Louise? And what do you think the demographics are for the nursing workforce in terms of ethnic backgrounds? Do we think that nursing is less diverse than the general population, somewhat less diverse, about the same, somewhat more diverse, or much more diverse than the general population? Okay, so we've got a range of answers here, erring towards more diverse, but somewhat less diverse in some is quite a popular answer too. Interesting stuff. Okay, could I have the next slide, please, Louise? So what do we think the demographics are for the nursing workforce in terms of the social class of people who enter into nursing registration? Do we think it's predominantly people from working class backgrounds, predominantly middle class backgrounds, or predominantly upper class backgrounds? Okay, so we are strongly preferring predominantly working class backgrounds, but with a good number of people thinking that it's also predominantly middle class backgrounds. Good, you guys are totally professional at this now. Can I have the next slide, please, Louise? Okay, so in terms of gender, 90% of registered nurses are women. In terms of ethnic backgrounds, 20% of registered nurses in the NHS are from an ethnic minority background, which is about 43% higher than the general population. And in some parts of the country, up to 40% of nurses are from ethnic minority backgrounds, such as London. It's also similar in terms of social care. So registered nurses in social care settings, about 40% from ethnic minority backgrounds. In terms of social class, about 40% of nurses come from working class backgrounds. Which is, if you contrast that against the proportion in medics, is about 4%. So the demographics of registered nurses isn't really generalizable to other healthcare professions or the general population, and there's a high intersectional representation of people who often experience inequalities in the UK. So our situation is we've got the largest clinical group in the provision of healthcare who provide a central role in direct patient care, are seen as lower in status and prestige, have higher levels of representation from commonly excluded groups, and are currently excluded from commonly excluded from obtaining the benefits associated with having clear job plans. So if we've kind of got to that position collectively in a sort of passive sense. But if I went to a policy governance group and said I want to introduce job planning, but I want to only favour this group and I want to exclude this other group who have a higher representation of commonly disadvantaged groups, there's no way that we'd get that through an equalities assessment. So there is an imperative for us to take action to address this disparity, and one of the reasons why I'm particularly keen to hear from people who have routinely and robustly done this with their nursing workforce. I've focused on nurses today because I've got the clear data for it. I mean, if we looked at support workers and other associated professionals, I'm sure there would be similar pictures, but it's, this is some of the arguments that you may wish to use in terms of structuring the cases within your organizations for making this change. So it's a whole, as I said, it's a whole workforce issue, optimizing capacity. So in order to do that, we have to include all clinical groups. We have to address the structural inequalities in the way that different professional groups are enabled to plan their time. And we have to have specific plans around addressing the learned cultural factors, because there is a really, the pull of this is the way that we do things around here. This is the way I've always practiced. This is the way I've always planned my time. And internalized beliefs around, I'm just too busy to do this. I'm too busy to find time to do CPD. I'm too busy to go to that reflective practice session because I've got all these things to do for my patients. They're the things that sustain the current position, and they're the things that we need to be minded of. So thank you. I hand back to my colleague, Sarah, at this point.
Thank you, Simon. And just taking on board what Simon said, really, and then moving into sort of really how do we implement job planning at a whole-scale, multi-professional way. I'm just going to focus a little bit on three particular areas. The first being perception and culture, the second being governance, and the third being really, the nuts and bolts of how we implement job planning at scale. So we've heard, haven't we, that job plans have historically been limited to specific professions where there is a higher professional status and less representation from groups associated with wider social marginalisation. So given that, implementing job planning across a multi-professional landscape could be seen as the first step in providing equality of opportunity to access their associated benefits by all groups. This will represent a significant cultural change, And so therefore it's important considerations given to a few elements in terms to how we do and implement job planning. So first really is around the strategic case for change. Is this clearly made? Does it include explicitly addressing those structural inequalities that exist in the professional support available to different occupational groups? Does the implementation plan include targeted approaches to ensuring that there is equity of access of benefits for staff within groups that may experience exclusion? Is there a clear communication strategy in place to sort of support the implementation, but also really to sort of really bring about the importance and the awareness of why job planning for all is important? Is there an equitable representation and engagement from all stakeholders? And is there opportunity for sort of that collective creation to ask questions, to contribute ideas and to receive feedback on the implementation stages? And finally, under this section, really, it's thinking about what's the impact of job planning. So the impact of job planning implementation on key stakeholders, is this formally assessed and reported upon? So, for example, through a quality and equity impact assessment. Next slide, please, Louise. So we think about this from a governance perspective. We've heard, haven't we, that implementation of job planning across all professional groups poses significant opportunities, but also challenges. And having a sort of clear governance is critical to support the implementation phase. So has there been consideration really to having sort of job planning working and steering groups? So that space to be able to really think about how this is going to work in practice. Is there a senior responsible officer to champion the implementation and to provide clear lines of reporting accountability all the way to board? Is there alignment to the wider workforce programmes? This will be critical really to ensure synergy with interdependent projects. So for example, any projects with e-rostering, recruitment and retention. And thinking about training early on is really important actually, because training will be required and it'll be required to be tailored to individual roles and responsibilities. And if we take on board what we've heard about sort of the differences in sort of the professional requirements for CPD, therefore we need to be thinking about that in a very individualised way. And finally, in terms of implementation, and some of this might be quite obvious, but have we got a detailed and well executed project plan? Is that actually in place before we set off? Do the policies and operating procedures that are in place support staff's understanding and implementation? Job plans, they need to be linked to that service and individual objectives, and that they need to be reflective of professional roles and the requirements to fulfil those professional roles. And finally, and probably most importantly really from a practical point of view, is there sufficient time to undertake job plans, and are there clear review cycles in place so we can ensure that we keep reviewing that and we know that what we're doing is effective? So at this point, I just want to hand over to my colleague Sean, who's just going to give you a couple of examples of job plans in action. Okay, Sean, over to you.
Thank you, Sarah. I am Sean Griffiths. I'm a mental health improvement manager in the team. And my experience is also in mental health nursing, similar to Sarah and Simon, in a number of operational roles across different services. First job plan that we're looking at is an individual job plan that's from a CYP community mental health team. And you can see that this is quite a structured job plan and how it's been set out. So we've got different slots that we spoke about earlier, and we've got different slots for like assessment sessions, clinical admin, group time, and also supervision. Something that isn't in here and could be put in here is CPD, like Simon mentioned, and also things like mentoring and ensuring that we've allocated that time for the clinician so that they could be more effective and more productive. But it's also essential that we engage with the clinician throughout, so that we're looking at the different slots and the amount of time we can adjust the plans so that they suit the service and the individual. We'd also look at how we can be a bit more effective and efficient, and we make sure that the clinician knows that this is an assurance tool and it's something that we're using to improve their productivity and to improve the outcome for patients. And next slide, please. The next slide we've got is this is a process that we used for a psychiatric liaison service. So it was a project that we had, and we got a plan from the start and use a project plan so that we could be quite clear in what we wanted to do. And the aim of the project was to accurately quantify the capacity within the psychiatric liaison services so that we could develop a demand and capacity resource, and wanted to develop a dashboard. So it was important that we could effectively map the capacity that we had within the team. So we wanted to improve productivity, improve patient outcomes, and so we could not only use it within the psychiatric liaison, then we could spread it wider across the whole urgent care service. So we ensured that we followed a process where we engaged with clinicians to start with, to look at because obviously the psychiatric liaison service is quite, we've seen a lot of different patients that have got a lot of different acuities and need a lot of different services, different referral pathways. So we needed to map out the processes across. We did process map to start with, to go across all of breaking down into individual tasks. And then we tried to then assign units of time to these tasks, both clinical and non-clinical tasks. And we worked with the clinicians to map a typical assessment and the associated admin within those assessments. So if we was getting referrals from, say, wards, how much time would we be spending on that, because we may have more complex referral pathway onwards, or if we get A&E assessments, then the acuity patients may be different. So we developed these in conjunction with the clinicians and revisited them so that we could adjust them as we moved along. And then we went to develop a draft individual one shift plan, and then moved on to develop individual job plans across the team. So we're trying to, and then at the end, we did a whole week plan. So then we could look at how we represented that in the dashboard, and we could match the demand against the capacity. And now I've just handed back to Michael.
Thanks very much, gang. So now that you've heard about some of the kind of practicalities about job planning, but also what kind of good job planning means and why it's so important, kind of revisit. We had the poll at the beginning about, with a number of people saying they did have job plans in place, and a number of people saying they weren't sure. And I guess particularly if you're in the not sure group, I suppose here's some kind of key questions to ask yourselves, or if you're from a commissioning background, maybe to ask your providers around your job plans. So the kind of simplest question is, do all the clinicians in your teams, that's all the clinicians, including nurses and other support workers, have a defined job plan that includes clinical time and non-clinical time, so they know what's expected of them each week, and so that importantly they have dedicated time for CPD, for example? Are they individual plans per person, not per role? Are they complete, and are they up to date? So a generic job description from 2017 does not an individualised job plan make. Secondly, do you know how many slots each practitioner is expected to deliver? So what we often see is the number of people on a caseload, or the number of morning or afternoon sessions that people are intended to do. Obviously that gives you some guidelines, and it's better than nothing, but certainly that doesn't count from an operational perspective as an effective job plan. Doesn't give clarity to staff about the detail of what the expectations are, and certainly doesn't give you as a service or as a manager the tools that you need to measure your capacity accurately for the individual or for a team or for a service. Slots are what you need to know. So how many assessment slots, how many treatment slots, how many CPD slots, whatever it may be. And then finally, as Sarah said, it's important that this is agreed transparently so that there's a fair and open process, both with individuals and within the team, so it's clear who's contributing what towards the team and why that is. And is that consistent across teams and across different areas of the organisation? Next slide, please. So we've talked about capacity, we talked about job planning. The other key element to optimising capacity is looking at activity. So whereas for capacity, we're talking about the number of slots, the number of future slots, we're talking now about past activity. So commonly measured in number of contacts. You might call it something different in your organisation, not important. The point is, it's what was done. So capacity is what's going to happen next week, we hope. Activity is what happened last week. So this is the actual number of contacts per clinician over a particular time period where a treatment or assessment or other intervention is delivered to a patient. This should be compared to the number of slots that were planned. So when you're comparing your delivered activity and your planned capacity, it's important to bear in mind that there are a number of factors that influence this, including DNA rates, travel time, sickness, absence, diary management, 100 different things. So it's a really important message that the concept of comparing activity with capacity is a valuable process in itself. It's not a finger-wagging exercise to try and check up on whether people are doing what they're supposed to do. It's an improvement process about saying what are the barriers to delivering what it is we want to deliver. So referring back to the beginning, everybody accessing services wants things quickly, and everyone providing services to patients wants to deliver them quickly and to deliver as much possible clinical time as they can. So this is a process about understanding the value of job plans per se, and then using those to help to learn about what the barriers are to delivering clinical activity. This should be routinely reviewed in case management supervision. So key questions for managers, for commissioners, whoever else it might be. How do you understand whether people are completing the agreed number of slots? So whether the activity which is being delivered is in line with the capacity which has been job planned. So you need to monitor this regularly. As I said before, acknowledge that performance will vary from expectations, and the purpose of this process is to understand why there is variation from expectations and to think what you can do about it, whether that's what you can do about it as an individual practitioner, whether that's what you can do about it as a manager in terms of freeing up time, whether that's what you can do about it as a service manager in terms of improving processes, or whatever else it might be. There's all sorts of good reasons why there'll be variation. And there has to be a clear and transparent monitoring process in place so that it can be managed transparently and fairly. And it's really important that easily accessible information is available from an IT perspective, so that in case management supervision, team management and so on and so forth, you've got a readily available report and people are not trying to trawl through individual records or arcane spreadsheets or whatever else it might be to try to get access to the information. It needs to be convenient, transparent, consistent and fair. Next slide, please. So there are different levels at which you can use the data which is available to you to try to improve. So first of all, with individuals. So are the job plans that you've agreed realistic and are they being delivered? So make sure that case management supervision has reviewing activity against plan as a standing agenda item. Make sure you're having a conversation with the individual, with the practitioner, about all the different aspects of their job plan, including CPD. And if they're not able to deliver what's in the plan, then what's causing the overactivity or underactivity in different areas. One important thing to note is, as often as not, you'll find people, because they don't have a job plan, feeling a pressure to deliver, particularly in the context of long waits, and often actually over-delivering against what would be a reasonable expectation. And as Simon and others have said, it's that kind of sense of responsibility and sense of being busy and sense of over-delivering which impedes things like CPD and other personal development. So then a conversation between the manager and the individual about what their needs are and what might be causing deviation from the job plan and what can be done to try to accommodate that. So then at team level, having had those individual conversations, it's about looking at variation. What variation is there across the team in terms of over or under performance? What are the factors driving this and are they warranted? There might be warranted variation. There might be different people or different specialisms within a team have different levels of acuity, different case mix. There might be some members of the team that cover more rural areas and have more travel time. There might be some members of the team that have more urban areas and relatively less travel time. There's all sorts of perfectly good reasons why there will be variation across the team. So ask yourself the questions: what's affecting delivery of the services? What's the explanation behind the variation? If there's unwarranted variation, then that's something that we want to try and improve on. You can look at the data on non-attendance around DNAs and cancer by practitioner and how they're managed. Very common to see significant variation in DNA rates from one practitioner to the next. We can ask questions about why that is and try and help everyone move to a higher level, well, a lower level of DNAs, in fact. And also to learn from what the common success factors are that are driving high performance. So where there are particular individuals or areas of the team that are performing well, what can we learn from them? And then finally, we can use that information that we got from the team discussions to respond to changing demand. So once we are able to understand how we're working as a team and what the criteria are that affects productivity, then we can look at how we want to deal with changing demand. Demand might vary at different points in time or different aspects of the pathway. So for example, in CYP services, we very often see an increase in demand around the beginning of the new school year, September, October. It's completely predictable and manageable. And in the context of regular conversations with individuals and within the team about how to flex capacity, that's something that could be planned and dealt with accordingly, so as not to have a negative effect on people's waiting times, make sure that young people and families get the service that we want to deliver to them. And if we know we've got increased demand coming, so for example, the increased demand as a result of the pandemic, then we need to have conversations about how job plans can be altered to move capacity around. It might be that we're seeing a higher level of severity in terms of presentation of people, so there's more demand for particular interventions and less demand for some of the kind of lower level interventions. So it's about how can we have a job planning conversation saying, right, we need to shift the balance from assessments to particular interventions, or it might be that we need to shift the balance from intervention A to intervention B. So being able to have kind of mature conversations about that within the structure of job plans enables the service to respond to changes in the demand and need. Next slide, please. And then finally, once you've got reliable information about your delivered activity, from a managerial perspective, it's important to be able to view that activity information alongside other data about your service. So data on waiting times, data on patient flow, the number of people entering treatment, the number of sessions that people are receiving, the dose, and the number of people being discharged, the number of people leaving treatment. Having that kind of balanced scorecard enables you to quickly understand where things are going well and where things are going less well and where the pressure points are in your service so that you can respond to them proactively and try and nip any issues in the bud before they build up into long waits and deteriorating service for people. Next slide, please. Now I'm going to pass over to my colleague Nick, who's going to talk to you about the mental health capacity tool.
Thanks, Michael. Good morning. My name's Nick Gitcham. I'm an improvement advisor with the team. I've been with the team for 6 years, and before that, I worked in the acute sector in various service improvement and program management roles. So I'm going to spend a couple of minutes just showing you our capacity tool, which you can download from our Future NHS platform and use. And it's a way of totting up your job plans to tell you what your capacity is in terms of the number of patients you can see. So this isn't a full demand and capacity model or tool, and we'll be flagging up some of those to you later in the presentation. There are a number of models that the NHS England demand and capacity team have produced, but this doesn't take into account the demand side of things. So it's important to understand variation in demand. And we touch on that in our next webinar on the 1st of November on backlogs. And it also doesn't factor in issues like seasonality, which Michael mentioned in terms of demand, but it does give you a good handle on what your capacity is based on the staff you have in the service or the staff you plan to have in the service, and what that means in terms of how many people you can see with the model you have. So it's an Excel spreadsheet. It has a few worksheets. The first one, I won't read all this out, but it's just guidance on how to use the tool, but I'm going to talk you through this. So if we go to the next slide, please. Here's where you start entering the data. So it comes pre-populated with some demo data, some example data, and you just overwrite this with your own data for your service. So you can enter in table 1 a number of interventions that the team you're modeling delivers, up to 10 interventions, and we've just got 3 as the example there. So an assessment with an average staff time of 0.75 hours, 45 minutes, short interventions with an average staff time of 1 hour, and CPT with an average staff time per contact of 1 hour. So in this column on the staff time, you can either include or exclude any admin time related to the contact or travel time. It's potentially easier and simpler just to enter this direct contact time, but it doesn't matter as long as you are consistent throughout in terms of how you're recording that data. And then in the third column, you enter the average number of contacts per person. So an assessment is an average of 1 contact per person in this example. Short intervention is an average of 4 contacts, and CBT an average of 6 contacts. So it's important here that you enter the actual averages, not the model of care. You may have a model of care, for example, in which CBT is 8 sessions, but you may be averaging less than that due to dropouts, or you may be averaging more than that because you can extend for certain groups of people. So this should be based on actual activity data from your service, which is generally going to be fairly readily available from your EPR or from reports linked to that. So that's the first worksheet. You enter the intervention names on the next worksheet. You can give the scenario a name, or you can model for different time periods. So you can model up to 4 scenarios, which could be what you have now and what you expect or plan to have in the coming time periods, to compare and see how that translates into your capacity. You enter how many working hours per week for a whole-time equivalent, which will generally be 37.5. And you enter your service sickness absence rate, which should be based on your actual sickness absence rate in the last 6 to 12 months, unless you think there have been extraordinary circumstances and you would expect that to be significantly different going forwards. Then you can just put in your expected future sickness absence rate. Next slide, please. And then the third worksheet where you enter data is where you enter the details of the staff within the team and their working patterns. So are they a whole-time equivalent, full-time or part-time? How many annual leave days each member of staff has per year? Obviously, that will vary slightly from team member to team member. Any study or other leave days that you expect that member of staff to have, but excluding the sickness absence, which we've already factored in. And then you can put in what you have in post. So you can list roles here or members of staff where you've got vacancies, but you do have an establishment budget for that member of staff. And then the next column is to enter, again, real-world data on what was actually delivered in terms of clinical contact hours, patient-facing time for each member of staff. So this isn't the job plan. This is what actually happened, which would generally be something different to the job plan. And that, again, should be available from your EPR system. And then the next section is on the slots offered or bookable. So for each of the interventions you've entered on the previous sheet, they'll be listed here, and you enter there the number of slots if that member of staff was working a full week, whatever their working week is, if it's 4 days or 5 days. If they did work a full week, how many slots would you expect them to be able to offer or book? So the tool will then aggregate up all the data you've entered in those 3 worksheets and come up with the results on the next slide, which shows you what the capacity situation is in numbers and in graphs. So in the large table here, the first one on the left-hand side, you've got the numbers for Q3 showing that you're paying for 305 hours per week of capacity. That's the total time that people are employed for. But of that, in this example, the actual maximum contact hours per week is 133, based on what you've entered in terms of the job plans and how much time you're expecting clinical contact time for. Then that gets reduced to the next column on the available contact hours per week based on the sickness absence rate and also any vacancies you have in the service. And finally, the last column is showing you what you've actually delivered over the last period of time that you're entering the data for. So you will lose some capacity there, either because slots haven't been booked in practitioners' diaries or schedules, which may indicate some scheduling issues, or the fact that you're not offering a range of convenient appointment times to patients, or it could be slots which are lost due to DNAs or people who weren't bought or that were cancelled by the provider. And then on the right-hand side, the final table tells you, given the capacity that you've entered on on the previous sheets. What does that mean in terms of the number of patients you can see for each of those modalities? So assessment, theoretically, you can deliver 610 slots, but based on what you've actually delivered over the last quarter or time period that you're entering the data for, you're expecting to run to 449. And then similarly for any other interventions that you enter here. So as I say, this isn't a full demand and capacity model. It doesn't take into account variances in the seasonality and ups and downs in the demand, but it does give you a good handle on what you can deliver based on the capacity you have now. And another way you can use the tool, instead of entering details of each individual member of staff on the previous sheet, you can just enter a team level aggregate total for the total capacity you have, and then you can use that to look at the split between the different modalities. If you've got staff who can deliver a number of different interventions or assessments and treatments, you can use that team level aggregation as a way of getting the right split between the different modalities, and then you can use that to ensure that individual job plans add up to the total that you're looking for. So a fairly straightforward tool, and just to say, you can download that now and start using that. And I'll now pass back to Simon.
Thank you, Nick. Can I have the next slide, please? I was going to talk a bit about the National Demand and Capacity team here, but we're fortunate to have Matthew O'Reilly from the National Demand and Capacity team on the call. So I'm just going to bring Matthew in and ask him to do the next two slides, please. Matthew, are you able to join?
Hi, Simon. Yes. Thanks for the introduction. So I'm Matthew O'Reilly. I work in the National Demand and Capacity Programme team and work closely with Simon and colleagues. And just a little bit of a introduction about the team and what we do. So we provide models and training free of charge, Excel-based models that cover a range of different service types, service areas, but essentially aim to support a better understanding of demand and planning capacity. So that really complements what we've heard this morning already, and it's been really good to see the detailed focus on understanding capacity, which really underpins any of the demand and capacity modelling exercises that you might want to undertake. And I think having that detailed view of your capacity, however detailed piece of demand and capacity modelling work you go on to do, then gives you a really detailed evidence base, and is really essential. So it's been really good to see this morning. So in terms of support and offers, as a team, we've got a range of resources available on the NHS England website, but also a dedicated Future NHS workspace, where you can access more of the tools that we've got available and guidance around using those tools. And there is a link there in the slide deck, which I know will be made available afterwards. There is some online training, which again, we've got a link there, and also an online open online course based on a series of different modules that run through different aspects of demand and capacity modelling. If you could move on to the next slide, Simon. Thank you. So in terms of models, then there's a series of Excel-based models that we have available that can be downloaded from the NHS England website or from the Future NHS workspace. We've got a number of what we've listed here as published models, and those are available on the NHS England workspace. A number of development models, which are models that are available from the Future NHS workspace and are available for use, but sales subject to further development work based on work that's ongoing with stakeholders at the moment. And you'll see from these that there's models that are essentially around an introduction to demand and capacity modelling through to more complex models, depending on where you might be in terms of the type of service or pathway you're working with, or the data or evidence that you've got available to use within that. And for those of you on the call today, there are models around urgent response, which might be particularly useful around crisis response type services, and one of our newer models, caseload model, which we've seen being used, and we've been working with a number of stakeholder organisations around community mental health teams using that model in particular. And then on our future NHS workspace, obviously there are additional resources that might be of use around case studies, series of presentations, and then various other guidance materials. So if you're interested in having a look, then the link's there. If you click on that link, then if you're not already a member, we can arrange for you to have access to those resources.
Lovely. Thank you, Matthew, and thank you for joining us today. Really grateful.
Thank you.
There is also another demand and capacity model that the colleagues in the mental health policy team commissioned called the CREST tool, that was initially developed for children and young people's mental health services, but it can be used in a variety of other settings within mental health. The link is here. It's a web-based platform. It doesn't require a huge amount of data points to make it go, and it has these produces these graphical representations, which can be quite helpful. There's also a team that provides support for people that are using that as well, so their contact details are here if you wish to use this one. Could I have the next slide, please? And at this point, I hand back to Michael. Thanks.
Thanks, Simon. So in addition to the resources from the demand capacity team, there's also a clinical workforce team within NHS England. The website and other information is available there. They've also got a features site, the link for which is in the presentation. This is a team that's focused on promoting e-rostering and e-job planning. So it's slightly out of the scope of what we're talking about today. So we've kind of focused on the basic building blocks of getting a job planning process up and running and having those conversations with individual practitioners. And the clinical workforce team are all about then incorporating that into your electronic systems, linking in with EPR and kind of online and digital rostering and job planning. There's contact details for them there, and they'd be really happy to talk to anyone who's interested in pursuing that. We've got some other links for you as well. In brief, there's a couple of other modules that are particularly pertinent, the backlogs and patient tracking modules. We've also got linked to Making Data Count at NHS England. I mentioned before the importance of being transparent and clear when you're monitoring activity, and that's got some top tips about how to report information in a reliable way. Quick plug for our system maturity tools. If you've got particular focus on children and people's mental health services or on adult IAT, then we've got some more comprehensive self-assessment tools for services to use. And a couple of links from the workforce team's website, one around job planning for AHPs, and a really useful guide to non-medical job planning language, so you don't get kind of bogged down in what counts as a patient-facing and non-patient-facing activity, etc. So now I'm going to pass over to my colleague Francis, who's going to talk us through a few polls.
Hello everyone. So hopefully you've got some useful insights from today. And we've got a few questions, as Michael says. So thinking on the cultural aspects of optimising capacity, what's going to be your greatest challenge? And so I want you to rank these in order of the greatest challenge first. Is it securing buy-in? Oh, you're very quick. Is it securing buy-in from staff to see the positive benefits? Is it achieving that psychologically safe discussion about the gap between planned versus actual? Oh, it's coming in at So the first thing is, I think in first place is securing buy-in from staff to see the positive benefits, and that's closely followed in by securing that dedicated time to enable staff groups to undertake developmental work. And of course, that's sort of one of the benefits that will come out of the job planning process, as Simon explained. So that's very interesting indeed. So securing buy-in, and that links to what Sarah spoke about. Okay. Are we ready for the next question? Right. So thinking about implementing job planning, again, ranking your greatest challenge first. what do you think is going to be the most significant barrier? Is it the organisational commitment to implementing and using job plans? Okay, we're away with that one. Is it availability of information itself, the data itself, to sort of enable that supervision process to happen, to see what the gap is between planned versus actual delivery? Or is it the capacity to support staff in those conversations, as Michael mentioned, in terms of looking at the barriers and the variation? Right. So I think the organisational commitment is turning out to be the biggest barrier, and closely followed by the information to enable the supervision process to happen. That's really interesting too. Excellent. Any more for any more? No? Can I ask that if you have any top tips or good practice in these areas, please drop them in the chat, and thank you to those of you who already have mentioned what you're doing in your local areas, and we really look forward to hearing about some of these. So please drop them in the Q&A box rather. So the third one is around the nuts and bolts of achieving the job planning itself. And again, ranking these in order. What is your greatest challenge? And you're all coming out saying that it's actually agreeing the available capacity per each clinical staff member, defining and agreeing expected contact levels across pathways is also a fairly equal challenge. And the third one, which is around sort of using QI approaches to freeing clinical time and reducing that non-adding activity that sometimes staff can, non-value adding activity rather, that staff can find themselves embroiled in. So again, okay, so agreeing available capacity with each staff member. So I'm really excited that we can hear from some of you, because I think it sounds as if some of you have gone through and walked this path. I think it'll be interesting to hear from your experiences. Gosh, you're all so good at this. Yeah. So I think this is a general one, a free for all, to get you thinking about what your main barriers are for implementing job plans within your team, trust or system. And we're going to do a beautiful word cloud here, I think, coming up now. Right. Ooh. So we've got culture magnified, got leadership. Oh, culture and buy-in. Yeah. Culture and buy-in. Culture, buy-in, capacity. So, don't you just love these? So culture, buy-in, leadership, time's also coming through. Leadership. Yeah. So I think you can see it there. Lots of you are clearly wrestling with this. Excellent. So we hope that's been useful to you, but we'd like you to share sort of on this, what has been the most useful thing that you've learnt in this session, perhaps that you didn't know before you came into the session. Good that it's possible. Some tools. Yeah. Right. So it looks like the tool that Nick showed could be helpful, which is great. I think it's probably job planning more generally coming out there, and perhaps it's the rationale, the benefits, perhaps as Sarah set out and Michael set out. Great. And I think we had a question about tools, and certainly Nick's tool that he took through, whether it can be converted into an app. I'll leave Nick to answer that shortly. Okay, and support's clearly important. Right. Wonderful, you're all so good and so responsive. Great. Thank you for your engagement, and we look forward to the next. So I think I will hand over now to Michael to round up, and then we'll have our Q&A.
Yes, thank you, Francis. So as Francis said, we're hoping that some of the mentees there have given you food for thought, and we really encourage you to contribute to the Q&A and the chat session, which is going to come up in a minute, about your experience of the good and bad of implementing job plans. And I know we've got a couple of people who've already contributed who are happy to share their experience, which is great to hear. So we talked about implementation support, and it was interesting to see a support offer coming through the word clouds there as one of the things that people were not aware of. So although we're a small team, we do offer implementation support. So in addition to these webinars, of which you're currently participating, we also offer coaching, consultation and support to systems, which tends to be brokered through regional teams. And for the most challenged systems, again through regional teams, that we also offer hands-on implementation support as well on the implementation of the mental health elective recovery tools and other parts of mental health management. Next slide, please. So we have an offer of consultation and support available to every system. So if you are working in a system and you would like support around any of the mental health elective recovery modules, not just around optimising capacity, we can offer support in terms of coaching of leads of change programs, attending key meetings, program boards, etc. Check and challenge, kind of critical friend approach to plans, and support with developing local approaches and sharing good practice and linking you with other areas. So if what we've talked about in the webinar sounds familiar to you, then please do make use of what's available on our futures site. Think about what your barriers and enablers are. So what kind of pre-work needs to be done so that you can be ready to run with any support we may be able to offer. And then do get in touch with us. The contact details are available at the end of this presentation, and we'll be happy to talk about how we can support your system. So, as you can see here, we do ask that you kind of commit to certain things, which is effectively having proper senior named leadership with accountability for delivery, identifying adequate capacity in a system to actually make some changes, identify clear reporting and accountability, and having project management or similar support to actually develop an implementation plan. If you can put these things in place, then please do get in touch with us, and we'd be delighted to work with you to try and bring about some improvements in your service or in your systems. Next slide, please. And finally, as I said, you can contact us via the regional leads as listed here. So if you're in the Southeast, for example, please do get in touch with me. Also, all the information is available, as I said, including this recording will be, and these slides on our futures site, and we'd encourage you to join, make best use of the resources, and also participate in our online chat facility to share good practice, and also to ask your colleagues for help. Finally, as I mentioned, this is the first of a series of webinars. There are forthcoming sessions on understanding backlogs, pathway, patient flow, patient tracking, access policies and commissioning. And you can also, if you're a real glutton for punishment, view our introductory webinar, which took place the week before last, and the recording is available to you there as well.